Oscar, stop gripping my hand so hard. Like it hurts, eh? Well, today we're going to look at the tendons of the wrist. So we'll start with the flexor retinaculum. So it's a strong fibrous band that's about 3 centimeters in width and length. The proximal landmark is the distal wrist crease. So if you bend your wrist up and the crease that's the furthest or the most distal, that's about the landmark for the proximal border of your flexor retinaculum. On the ulnar side, it attaches onto the pisiform and to the hook of the hamate. And then on the radial side, it attaches onto the scaphoid and the trapezium. It strengthens the carpus and it increases the flexor tendon efficacy or efficiency. And it forms a tunnel through which the flexor tendons and within their synovial sheaths and the median nerve pass. Clinically, it's a very important site for compression of the median nerve. So here we see it here. So we have the median nerve that's passing underneath, the flexor tendons that pass underneath, and this is your flexor carpi radialis tendon. You can see it doesn't actually go underneath, it goes through the flexor retinaculum. The extensor retinaculum goes, it's dorsally, but it's an oblique band, which actually starts more on the palmar side. So it inserts into the anterior triquetrum and pisiform, and then it does wrap around obliquely, and it goes around to the dorsal lateral surface of the radius. The extensor tendon sheaths pass through this tunnel. So there are 6 different compartments. The first compartment is your extensor pollicis brevis and your abductor pollicis longus. They make up part of that lateral border of your anatomical snuff box, or la tabatière. And then the second compartment is the extensor, both the radialis brevis and longus. Your third compartment is your extensor pollicis longus, and that makes up your medial side, or the ulnar side of your anatomical snuff box. But here you can see that it is more medial to the extensor carpi radialis brevis and longus, because after the extensor retinaculum, it crosses over in order to be going towards the thumb and insert into the distal phalanx. Your fourth compartment is your extensor digitorum and extensor indices. The fifth compartment is your digiti minimi. And then the last compartment over here is your extensor carpi ulnaris, which we already saw how it helps to reinforce the lateral collateral ligaments and the TFCC. I just wanted to show you, this is the surface, the dorsal surface, because if we're talking more about the extensors, it's obviously going to be on the dorsal side. And I want you to take note, you probably can't see what's written here, but this is a dorsal surface. But this here is the origin of the flexor carpi ulnaris. So it is actually quite on the, it's on the dorsal surface, but it's on the radial side of the dorsal surface of the ulna, and that is the flexor carpi ulnaris. And then you have the profundus, which also extends slightly dorsally for the flexor digitorum profundus. One of the muscles here we have that goes over both the radius and the ulna, as well as the interosseous membrane, is your abductor pollicis longus. And then over here, attached between the ulna and the interosseous membrane, we have both the extensor pollicis longus, so it's about the mid shaft, and then just distal to that, we have the extensor indices. And more on the radial side, and distally, we have the extensor pollicis brevis. So keep those in mind when you go to palpate these muscles, because if you know where the origins are, and then you resist the movements, you can easily find those muscles. The palmar aponeurosis is a strong triangular membrane overlying the tendons in the palm, and it provides protection for these tendons. It originates at the flexor retinaculum and inserts into the metacarpal phalangeal capsules. So the metacarpal phalangeal capsules here, the proximal phalangeal bases, and as well as the flexor tendon sheaths. They're also digital sheaths for the tendons. The apex is continuous with the palmaris longus and is anchored to the flexor retinaculum. And of course, sometimes what we see is when there's fibroblastic proliferation, this can cause the Dupuytren's contracture, which is most prevalent in men and most prevalent in the fourth and fifth digits, particularly the fourth. It differs from the trigger finger as in you do not have the catching that you get with the trigger finger. It's treated either with cortisone or surgery. And the surgery is a zigzag insertion so as not to become shortened post-surgically. The tendon sheaths. So we have synovial sheaths that are there to protect and lubricate to allow the tendons to glide more easily. And the sheaths attach the underlying bone and enclose the tendons in a fibrous tunnel. So we have the synovial sheaths that extend past the flexor retinaculum, and you can see it here. So what passes in the carpal tunnel? So we have the flexor digitorum superficialis, flexor digitorum profundus, and they are both within that same synovial sheath. We have the, oh dear, the flexor pollicis longus, not the extensor pollicis longus. There's a typo there, and it's also within its own synovial sheath, and then the median nerve. And as I said, the flexor carpi radialis does not pass under the flexor retinaculum, but rather it's through it, which means it's not really part of the carpal tunnel. We have digital sheaths, so they encase the finger flexor tendons from the mid-carpal necks to the DIPs, depicted here in the red. Surgically, this is known as the no man's land because it's particularly difficult to perform a successful surgery in this area. And often you can have synovitis within these digital sheaths, and that is what may create that catching or your trigger finger. The extensor tendon sheaths protect and lubricate the tendons as they pass under the extensor retinaculum, and they extend approximately 1 centimeter distal to the extensor retinaculum. We don't tend to get as much pathology or synovitis in this area. Your flexor pulley tendons, they reinforce the digital flexor tendon sheaths. The fibrous layer of flexor tendon sheath condenses into both the annular and cruciate or oblique pulleys. This keeps the flexor tendons closely attached to the bone or closely butted up against the bone and allows small changes in tendon tension to create joint movement, and this prevents tendon bowstringing. And loss of this pulley integrity decreases the flexor strength or efficiency. So you can see here the annular ones, which are annular and go around, and then the cruciates, and they help hold that tendon against the bones. But if they are ruptured, well, then you get this bowstringing. So then the tendon moves away from it and it's less efficient. You can also get the anatomy of the specialized soft tissue of a finger. This is how you can also get this pulley system in order to be maintaining one joint in extension, the other in flexion. But of course, then if there is too much tension, say on the extensor side, then you can create these swan neck deformities. Volar plates. The flexor tendons continually run against the anterior aspect of the metacarpal phalanges, and this causes a capsular thickening and sort of this groove or this plate of collagen, of dense collagen forms. It's attached strongly to the phalanx and loosely to the metacarpal phalange, and so moves with phalanx movement. Fibers from the collateral ligaments and the whole of the accessory ligament insert into the volar plates. So the dorsal expansion or extensor hoods are a triangular aponeurosis overlying the dorsal, radial, and ulnar aspects of each proximal phalanx, prevent extensor tendon bowstringing, and they aid the metacarpal phalange flexion and IP extension by muscular attachments. So basically what happens here is because of this type of movement, we can have flexion at the MCPs while still having extension at the PIPs and DIPs because of the dorsal expansion hood. So it will cause flexion here and then pull along here and gives extension to the distal joints. Thank you.